Now, ambulatory surgeries refers to the patient being discharged shortly after surgery from the hospital on the same day of surgery. So, requirement for ambulatory surgery are rapid onset and offset of anesthesia, rapid recovery, mobility and micturition, and good control of post-operative pain and nausea. Ideally, so next.
1 minute.
Ideally, GA is the popular choice for spinal anesthesia. Ambulatory surgeries. Spinal anesthesia is often avoided because of time required to administer it, its prolonged onset and delayed offset. But however, introduction of shorter acting local anesthetic, now a renewed interest in spinal anesthesia. Benefit of spinal anesthesia that make it desirable for ambulatory surgery is our avoidance of airway manipulation, avoidance of adverse effect of various drugs used in general anesthesia. It's beneficial in patients with comorbidities like obese patient, where we can avoid airway and aspiration risk is less. Pulmonary disease patients, spinal has minimal effect on pulmonary physiology if motor block is kept below T6 level. In GID patients are benefited with due to decreased risk of pulmonary aspiration. OSA patients benefited by avoidance of various drugs like benzodiazepines and opioids, which causes respiratory depression. And in diabetic patient, we can return to oral intake early than general anesthesia. Also, spinal anesthesia associated with reduced cost of care and facility resources utilization. Improved patient engagement, in which patient can observe certain aspects of their procedure and can interact with surgeon, which most of the surgeon don't like. Pain, spinal anesthesia associated with reduced post-operative pain score and decreased need for analgesia. Also reduced post-operative nausea vomiting compared to general anesthesia. Now, ideal intrathecal agents for ambulatory surgery should have these properties like rapid onset of motor and sensory block, predictable regression within acceptable time frame, and low incidence of adverse effects. History. Initially, lignocaine was preferred agent for which provides days block and rapid recovery. But due to various cases reported of transient neurological syndromes, it is no longer used and not licensed. Then only local anesthesia license for intrathecal use have been hyperbaric bupivacaine in USA and UK and plain levobupivacaine in UK. But they are longer acting. In 2010, hyperbaric prilocaine 2% license for spinal anesthesia in UK, followed by chloroprocaine in 2013 by USA and UK. These two are shorter acting and fulfill criteria for ambulatory surgery and are the drug of choice for ambulatory surgeries. Now we will see various local anesthetic available for intrathecal use. Lignocaine. Lignocaine has rapid onset and fast recovery. In early 90s, several cases, as I said earlier, of transient neurological syndrome arose, so no longer licensed for intrathecal use. It lasts for 90 to 120 minutes. Bupivacaine is longer acting local anesthetic, widely used for intermediate to long duration of surgery. It has onset of block in 5 to 8 minutes and lasts for 1.5 to 3 hours. Regression of the block below S2 level, allowing mobilization and micturition, is approximately 4 to 6 hours. Though low dose of bupivacaine, as we used, is 10 milligram, associated with shorter time to warding and discharge patient from home. Unilateral spinal anesthesia we use with 4 to 5 milligram has reduced recovery rate to 3 to 4 hours. Levobupivacaine, isobaric levobupivacaine have shorter duration of sensory and motor block than hyperbaric levobupivacaine, but still time to mobilization is more than 5 hours. So generally not recommended and not routinely used. Bupivacaine is longer acting local anesthetic, but associated with lower toxicity than bupivacaine. It has shorter duration of sensory and motor block and low incidence of hypotension and bradycardia than bupivacaine. Mean time to mobilization is still 4 hours. It is not licensed for intrathecal use in UK and USA. Mepivacaine is shorter acting local anesthetic similar to lignocaine. Block produced by 45 milligram of 1.5% mepivacaine lasts for 3 hours. But the frequency of transient neurological syndrome are similar to lignocaine, so not recommended nowadays for intrathecal use. Articaine is also short-acting local anesthetic, has fast onset, producing acceptable anesthesia lasting up to 1 to 1.5 hours. Time to spontaneous voiding is 3.5 hours. The preservative-free preparations of articaine are not available and only approved for dental surgeries, not licensed for intrathecal use. Prilocaine is local anesthetic with fast onset, intermediate potency, and intermediate duration of action, approximately 90 minutes. It is associated with low incidence of transient neurological syndrome. Prilocaine with the dose of 40 to 60 milligram lasts up to 90 minutes. Time to discharge patient is dose dependent, but may be discharged patient within 4 hours. For perineal surgeries, we use low dose 10 milligram. Relatively, it is contraindicated in sickle cell disease because of methemoglobinemia caused by orthotolidine metabolite of prilocaine. Next. Next is chloroprocaine. It is local anesthetic with very short duration of action. It lasts for 1 to 2.5 hours. It has rapid onset of sensory block within 3 to 5 minutes and duration of block is dose dependent. Still, complete resolution of block occurs within 1 to 2.5 hours with 30 to 60 milligram of drug. It has very low risk of transient neurological syndrome. Chloroprocaine preparation is isobaric, so saddle block is difficult to achieve consistently because of isobaric nature. This is the overview of local anesthetic I have mentioned. Just a little unclear chart, but it included with dosage, drug volume, and duration of the local anesthetic. Intrathecal opioids, fentanyl and sufentanil widely used in conjunction with local anesthetic to improve intra-op and post-op analgesia. But opioids are associated with high rates of pruritus, nausea, post-operative nausea vomiting, and post-operative urinary retention. So routinely not recommended. Now how to do it? So we have options available are low dose bupivacaine, bupivacaine or propivacaine with or without opioids, hyperbaric 2% prilocaine, and isobaric chloroprocaine. Bupivacaine with or without opioids. Bupivacaine may be too much because of longer duration of action, heavy legs for a long time. Retention of urine is significant risk, and opioid, if used, can cause pruritus and causing delayed discharge. And bupivacaine is avoided if possible if procedure is less than 2 hours. Now, heavy prilocaine, it has intermediate duration of action. It lasts for 90 minutes. So license for 90 minutes of surgical time. Up to 120 minutes can be achieved for knee, foot, and ankle surgeries. So less used for hip surgeries. Hyperbaric property of it allows manipulation of height of the block. And evidence of cardiovascular stability compared with bupivacaine is increased. It fills gap between bupivacaine and chloroprocaine in terms of duration of action. Allows daycare surgery without need of intrathecal opioid. Lastly, isobaric chloroprocaine. It is a very short-acting local anesthetic. Lasts for 40 minutes of surgical time. 60 to 80 minutes can be achieved for knee and ankle surgeries, so not used routinely for hip surgeries. Less easy to manipulate height because of its isobaric nature, but rarely about E10 level achieved with this drug. No case reports of urinary retention reported. With very little perineal lag, patient may be confident to mobilize sooner with chloroprocaine. Now targeting spinal to the procedure. So ask 3 questions every time in terms of surgery. Is saddle block required or hair block required? And the procedure is for short duration or intermediate duration. So depending upon this question, we use our select our drug and the dose required for surgery. This is little unclear, but in next slide it is clear. So if saddle block is required, so saddle block we use for various perianal surgeries like hemorrhoids, fissure, fistula, abscess, and perianal abscess or vulval surgery. So if saddle block is required, we can use pilocaine with low dose 10 to 20 milligram, that is 0.5 to 1 ml only, or we generally use bupivacaine 5 milligram, is 1 ml. If more than T10 block is required, then pilocaine with little higher dose 60 milligram, that is 3 ml can be used, or routinely we use bupivacaine 2 milligram. Sorry, 2 ml 10 milligram. Various surgeries like epigastric or umbilical hernia, gynecological procedure like diagnostic laparoscopy, and uro procedure like urethroscopy with stenting, where T10 more than T10 block is required, where we can use pilocaine with little higher dose. In terms of duration of surgery, if surgery is lasting for more than 1 hour, then pilocaine with 40 to 60 milligram, that is 2 to 3 ml, can be used, or bupivacaine 2 to 2.5 ml we generally use with or without opioids. In procedure like inguinal hernia, general surgery procedures, bilateral hernia, bilateral varicose vein, or ortho procedure like ACL, and some gynecological procedures. If surgical time is less than 1 hour, then we can use chloroprocaine, which is very short acting. Dose is dependent upon the surgery. We can use 40 to 50 milligram, 4 to 5 ml of chloroprocaine. Okay. So first time users, follow the guidelines on the decision making chart. Try pilocaine first if unsure, because it is intermediate acting. Be generous. Remember these drugs. Remember that these drugs are not low dose but short acting. Don't use opioid if possible. Know your surgery and your surgeon. Expand your use as you become confident. So various discharge criteria after spinal anesthesia: regression of sensory and motor blockage. Complete regression of sensory and motor block is required to ambulate patient. So ability to ambulate, ability to wide urine, steady gait, and no dizziness. If these criteria are fulfilled, then we can discharge patient. Potential complications associated with spinal anesthesia are delayed mobilization, full return of sensory and motor function required for mobilization, postoperative urinary retention. Spontaneous micturition is last function to recover. Requires regression of sensory block below S3 dermatome is required for spontaneous voiding of urine. Pilocaine and chloroprocaine associated with lower risk of postoperative urinary retention. Also, we can avoid excess of fluid to avoid postoperative urinary retention. Post-dural puncture headache, which whose risk is unaffected by local anesthetic use, but To avoid PDPH, it is recommended to use smaller bore needle and limit the number of attempts required for spinal. Hypotension, bradycardia, neurotoxicity, and nerve injury, though major complications are not reported, and possibility of failed spinal. So, providing effective ambulatory spinal anesthesia service, we need to make available drugs like prilocaine, chloroprocaine, or bupivacaine or opiocaine, which we generally used. Education to surgeon, preoperative, operative theater, and recovery staff is important for better success rate of for ambulatory surgeries. Advice how to supplement analgesia with local regional technique and systemic analgesia should be provided. And the conclusion is spinal anesthesia can be used for ambulatory surgeries. Low dose of bupivacaine or opiocaine is good option. Also, availability of intrathecal prilocaine and chloroprocaine have increased option available to the anesthetic, providing more effective and predictable anesthesia. An adverse effect of ambulatory spinal anesthesia, including delayed mobilization, post-operative urinary retention, are reduced with shorter acting agent, making spinal anesthesia safe, effective, and economical alternative to general anesthesia.